Hello everyone. Today we'll be talking about clinical management of the shunts. In the previous lecture, we learned what is shunt and how to calculate shunt fraction using arterial blood gas and mixed venous blood gas. We also discussed about other ways to calculate the shunt fractions, and we discussed why don't shunts respond to oxygen. So what are the causes of shunt? The causes of shunt include pulmonary diseases and cardiac diseases. The common things like pneumonia, pneumonitis, ARDS, these are the commonest form of pulmonary shunt. You can have shunt from atelectasis, lung cancer, and AV malformation. In cardiac disease, things like patent foramen ovale and Eisenmenger syndrome or tetralogy of Fallot, these will result in right to left shunt. How do you work them up? You can get a chest x-ray you can get a ABZ and VBZ to calculate the shunt fraction. Ideally, you should get mixed venous blood from a swan, but you can also use VBZ from the central line, remembering that the things may not be very accurate. You can get echo with bubble if you want to differentiate intracardiac and extracardiac shunt. And you can get a CT chest. If you want to look for AVMs, you have to perform a CT angiogram. So how do I improve oxygenation in a shunted physiology? The easiest thing would be to give them PEEP. PEEP helps them recruit the alveoli and decrease the shunt. Only patients with recruitable alveoli will be responding to PEEP. Again, whenever you increase the PEEP, always look for risk and benefit of increasing the pressure in the lungs. Second thing is by increasing the FiO2. There will be small increase in the PO2 even with shunt physiology. One of the things to remember is as the shunts do not respond to oxygenation, the converse is true as well. That means if you're setting around 95% on 100% FiO2, you might be able to drop down the FiO2 significantly without much dropping in percentage sats. And this is important because you can reduce the complication associated with high FiO2 without really affecting your oxygen content in the blood. Positioning is the simplest way to improve oxygenation in a shunt. Let's see how it's done. You might have noticed on the rounds that turning patients can often result in hypoxemia or worsening SATs. So let's talk about west lung zones. So we have a right ventricle which unfortunately cannot generate a lot of pressure, and it has to generate pressure against the water column of around 25 centimeter. That is the height of the lung. The PA pressures are around 20 by 10. That's your systolic and diastolic pressures. So there are areas on the top of the lungs which would unfortunately be not perfused. The middle part of the lungs, that is, we call it zone 2, would get perfusion only during systole but not during diastole. And the bases of the lungs are the areas which get perfusion both during systole and diastole. So if you look at the amount of oxygen that your lungs are providing you, around 80% of that oxygen is coming from the lung bases, 20% from the middle, and almost 0 from the top. Now this is under normal resting circumstances. So let's understand this in a little bit more detail. We know that pneumonia is a shunt, and here we have a chest x-ray showing we have got right lower lobe pneumonia, and that's where the shunt is. The oxygenation in this patient is occurring mostly from the left lower lobe and a little bit from the middle zones. SATs are around 90%. Let's see what happens if we turn the patient. If we turn the patient on the right side down, now you can see that your shunt still remains in the zone 3. However, a better part of the lung is in now zone 1. The whole left lung is in zone 1. So your effective area of oxygenation has dropped down by quite a lot, and you can have desaturations. If you put this patient on the left side down, you have put the good lung in the zone 3 physiology, and the amount of area where oxygen exchange can happen, increases by a lot. So using this knowledge of putting the shunt in zone 1 can help you oxygenate your patient better. Have you ever noticed that patients with left lower lobe pneumonia or atelectasis always end up hypoxemic, but those with upper lobes do not? Keep an eye on that when you see your next patient. And this is again because pneumonia is a shunt, and if pneumonia is in zone 1, that is the top of the lungs, that doesn't affect the oxygenation. One of the ways proning works is by placing the good lungs in zone 3 and bad lungs in zone 1. And thus you can bring the normal looking lungs to the area which are well perfused. Now this is one of the many ways proning works, and we'll talk about how proning helps oxygenation in some other video. Does the shunt increases the partial pressures of carbon dioxide? Yes, it does. However, PaCO2 doesn't begins to rise unless the shunt fraction is very high, up to 40 to 50%. And even at this level, the effect is around 3 to 5 millimeter rise in the PaCO2. How does cardiac output affect a shunt? If your cardiac output drops, the first thing you already notice that your venous content, the PVO2 drops significantly, and if this drops, obviously your PO2 is going to drop as well. However, decreasing the cardiac output also decreases the blood flow through the shunt, and this is because low flow state cause more hypoxemic vasoconstriction, thus decreasing the shunt area, and they can improve the PO2. So overall, these two effects balance out, and there is no effect of cardiac output on the shunt. So we talked about causes of right to left shunt. Now 3 of them are anatomical shunts, especially the cardiac and AVMs in the lung. Sometimes it's important to differentiate these, and we use bubble study to evaluate the anatomical shunts, which can differentiate intracardiac versus extracardiac. So in a normal bubble study, bubbles cannot pass the capillaries, and if there are no shunts, you will not see any bubbles on the left ventricle. However, if there is an AVM, you would see the bubbles appearing in the left ventricle after a few cardiac cycles. However, if there is an intracardiac shunt, like in PFO and Eisenmenger syndrome, the bubbles appear almost immediately in the left ventricle. That's how you differentiate intra and extracardiac shunting. Have you heard about this word platypnea? Well, platypnea is opposite of orthopnea. Here, patient is dyspneic when sitting up and feels better when lying down. And this occurs mainly in cirrhotics who can develop AVMs at the base of the lungs. And the physiology is same as we talked about. If you got AVMs in the bases in an upright position, all these things are in zone 3, resulting in more hypoxia. However, if they're lying down, you can move these AVMs into zone 1 or 2, and that can reduce the hypoxia because of the reduced blood flow through the AVMs. So in summary, shunting is a common cause of hypoxemia, and you can calculate the shunt fractions, but you will need an ABZ and a VBZ, ideally from a mixed venous from a swan. However, you can use it from a center line as well. It's a lot easier to use nomograms unless accuracy is required. Always evaluate if you need to rule out cardiac causes for right to left shunt, because some of these things can be treatable. Shunts don't respond to oxygen, so attempt to minimize your FiO2 to target arterial sats of 90 to 92%. You can treat hypoxemia from shunting using PEEP or positioning. Try to position shunted area to zone 1 to improve oxygenation, and beware of placing shunts in zone 3.